Hello, everybody. From Spain, my name is Dr. Carmen Castillo-Gallego. I'm a geriatrician at Hospital Virgen del Valle in Toledo, Spain. And it is a pleasure for me today to introduce today's speaker as a member of the organizing committee of this Frailty seminar series. First of all, I would like to remind you a few things. At the end of this talk, we'll have a few minutes for questions and answers. So if you don't mind, write your questions in the Q&A section that you have on the screen below, and avoid using the chat feature, please. We will be very grateful. We would also like to remind you that it is important for us so that you fill up the evaluations that we will send you at the end of the webinar. And also remind you the purpose of the Global Frailty Network, which is a network to exchange and share evidence-based practices and research advances about all aspects of frailty. Healthcare professionals, researchers, policy experts, trainees, and organizations are welcome to join the network. And the last reminder is the ICFSR meeting of 2023, which is taking place from March 22 to March 24 in Toulouse, France. And the Global Frailty Network will be there conducting some interviews to keynote speakers. So with no further delay, I will introduce Dr. Leocadio Rodríguez-Mañas, who is going to talk about frailty in the hospital and after discharge. Professor Rodríguez-Mañas is the head of the Department of Geriatrics at Hospital Universitario de Getafe, Madrid, Scientific Director of the Spanish Network of Research on Frailty and Healthy Aging. Professor Rodríguez-Mañas holds many other key positions, including co-director of the epidemiologic study, Toledo Study of Healthy Aging, involving 2,845 community-dwelling older people, director of the Global Aging Research Network of the International Association of Gerontology and Geriatrics, and founding member and past president of the Academia Latinoamericana de Medicina del Adulto Mayor. Professor Rodríguez-Mañas is the principal investigator in 36 research projects and sponsored by either a public agency or the pharmaceutical industry, both national and international. His research focuses on the basic clinical and epidemiological investigation on aging, frailty, and cardiovascular risks like diabetes, including technological developments for detecting and managing frailty at different settings of care. He has authored more than 420 indexed scientific papers with H-index of 67 and 14,356 citations, published in prestigious scientific journals and several books, book chapters, and technical reports. Professor Mañas has also produced technical reports on several aspects of aging, frailty, and diabetes in the senior population for national organizations such as Ministry of Health, scientific societies, research organizations and agencies, and international organizations such as World Health Organization, Pan American Health Organization, Directorate General of Health and Food Safety, International Association of Gerontology and Geriatrics, governments of Mexico, Costa Rica, Chile, etc. So Dr. Mañas, if you can share your screen, you can start whenever you feel ready. Thank you so much for participating.
Thank you, Carmen, for your very, very kind introduction. And it's for me a pleasure to attend this invitation to share with all of you around 1 hour. I hope that in 45 minutes, I will release my lecture, and then I will be very happy to answer your question. As Carmen has told to you and Jorge said to me, I'm going to talk to you about this issue that is frailty at the hospital, but also after discharge. For doing so, I have split my lecture in these 6 bullet points with a final bullet about conclusions. First, I will try to summarize the conceptual framework that is supporting the way of geriatrics doing things with patients in the hospital, but not only in the hospital, because the conceptual framework is the same, no matter the setting of care. Second, how, coming from these theoretical issues, we organize the process of a comprehensive and continued management of these patients. And then I am going to put the focus in four main issues. First, how are we going to assess frailty in hospital settings? Second, how can we improve our management in the emergency department, that it's a very critical part of the hospital to attend all the people. Some approaches to improve the management during hospitalization, and finally, how can we improve the management at discharge? Taking into account the characteristics of this frailty network, I have tried to support what I'm going to tell you in some of our own research results. So let's go. What is the real problem when we face all the people? You know that we are very close to the human limit of the lifespan. So to improve, to increase the lifespan is now a very, very, very difficult task. And this is why when geriatricians think on how to do the things, we are more usually thinking in prolonging functional status, in prolonging what has been called the healthy lifespan, to prolong longevity by itself. So our main aim is to avoid what is happening in the right side of this slide and to promote what is appearing in the left part of the slide. And for doing so, we need to establish what is the biological age of each patient. In these two other people, we can speculate about who of them is biologically older. And for doing so, we have developed some concepts, and we have now, we are quite confident about the role of functioning as the main manifestation of the biological age of individuals. And there are many, many, many explanations for this. Probably this is not the moment to talk in depth about them, but all of you know that the phenotypic manifestation of aging plus diseases in other people is function. And this is why we used to assess function in every patient. And this is because the model of disease when you are aged are absolutely different to the model in younger people, not only in young people, but also in young adult people. So as we age, the role of disease is going down, down, and down. Although people who are older have many diseases, the impact on the real life is lower, but at the same time, the role of function is higher and higher and higher. And this is true for the clinical manifestations of the disease, the pathophysiology, the prognostic value, and indeed for the markers of efficiency. And this is one of the things that are supporting the need for a very different clinical management when we face other people. Some examples of what I have just told to you. This is a very classic study from the group of Università Católica de Sacro Cuore. Professor Landi published more than 10 years ago, that in people who are with functional impairment, although they have the same comorbidities that this other set of people, their life expectancy is quite lower. The difference between these patients and this patient is not the number of diseases, is not the diseases, but it's the functional status at the baseline. This has been reproduced several times in many studies. This is another one by Hogendick et al. In the Fradea cohort in Spain. And indeed, in the Toledo study of healthy aging, we also have some data supporting this fact. This is how Charlson Index is not able to prognose the risk of hospitalization, but the Frailty Trait Scale is able to predict quite clearly the risk for being hospitalized. Indeed, in this, an issue like hospitalization that is classically very linked or tightly linked to disease, was indeed when you measure the risk of hospitalization, function is able to predict more accurately than disease this risk. This also happened, for instance, in people with chronic diseases. This is a study published some years ago when they look at people in transplant, renal transplant waiting list, and look at the risk of mortality. The risk of mortality that was clearly dependent on the presence of frailty, but not so big by age. Frailty is the main factor predicting the risk of comorbidity and mortality in people in transplant waiting list. And it's also the case for acute disease. This is a study that we published some years ago about mortality risk in patients hospitalized by COVID-19 during the first wave. And again, you can see that in addition to gender and age, function assessed by Bartle Index was the main determinant of mortality in these patients. And indeed, we will be able to make a risk table of mortality using age, gender, and mainly Bartle Index. So taking as a whole of these things, a new biomedical paradigm has appeared that is healthy aging. Taking into account the compression of morbidity, the focus is not to prolong longevity, but prolong healthy longevity, the optimal longevity. And inside this conceptual framework, the WHO has defined this healthy aging as the process of developing and maintaining the functional capacity, making possible the well-being when you age. If you look to this definition, the term disease does not appear. So this is a big change in the paradigm. And now health is defined in terms of functioning. If you are functional, you are not sick. You have a healthy aging. And the main determinants, of course, are genetics, are also lifestyle, and some few chronic diseases. This evolution of the functional capacity is determined by these conditions and goes and happen along your life. And in addition to these decreases in functional capacity, there are also decreases in functional reserve. So there is a time when little stressors are able to put you in the risk of dependency. And at the same time, it put you in difficulties for coming back from disability to robustness. And this is because there is a time along this pathway from robustness to disability when the time for detecting and intervening is the most productive. And this is frailty. Frailty is the stage, the pathway from robustness to disability and death when you are still with enough functional reserve, not too much, but some functional reserve to recover before becoming disabled, when the possibility to recover to a robustness situation is unlikely. Frailty not only impact on your individual quality of life or your individual risk of death or your individual risk of disability, but probably is one of the most important factors associated to the sustainability of the health system. These are data from the Medicare, and it shows how frail elderly who are here in this part of the slide, that are only present in 8% of the 10% of patients attended by Medicare in the highest part of the coast, are able to account for 40% of the cost of all of these high cost patients. So 8% of them, of the population, account for 40% of the costs in Medicare, in more than 6 million patients. And moreover, when they were to assess which percentage of these high costs were avoidable, they found again that is the case of the frail elderly, the group where these costs are more probably to be avoided. In fact, 51.2% of the costs were possible to be avoided with interventions. So in this conceptual framework, the current systems can choose between prolonging the management of the failure or trying to succeed, making these patients are not longer said and attending, or they represent a very, very low percentage of the people attended by the health systems and the doctors, and in our case, by geriatricians. And because of that, it's very important to bear in mind the need for assessing functionality, the functionality of the patients, not only to diagnose them, but also to manage them, and also to put the main objectives to be achieved in each of them, taking into account that function is a dynamic state, and that depending on it, the care is going to be focused in different achievements, in different objectives, no matter the setting of care, but of course, also in the hospital and during hospitalization. So I would like to communicate you this global idea of the patient. The patients are going to be everywhere in any setting of care with changing needs, with changing manifestations, and because of that, with changing objectives of care, no matter the place. And second, and also very important, we must bear in mind, indeed, when we are attending an acute patient at the hospital, that in 7 days, 15 days, 2 months or 3 months, he or she will not be longer in the hospital, but she will be, or she will stay as a geriatric patient, and need to be this in mind in order to build a proper care plan. Because you know that the communication between all of these settings of care are full of barriers. And one of the aims of the geriatricians and the geriatric system is to overcome these barriers, making the easiest the communication between the patient and her carer, with all those actors involved in caring for him or for her. And mainly in the transitions that are, as all of you know, very risky situations. So with this conceptual framework, there are several proposals of organizations by different institutions. This is the case, for instance, in the United States. There is a nice group of research trying to check what is the best way of providing this service and what is the patient that could be the focus for these models of care. As you can see here, patients who are very fitted, no benefits from these models of care. Those who are very poor, no benefit from this model of care. But these models of care can be mainly focused in these who are in the middle. They have some long life expectancy, they have multi-comorbidities, and they have start to experience some functional impairment or at a higher risk for doing so. This is one of the models in the United States. But not only for people at risk, but those who are frailty in Europe, we have developed several models. This is the Scottish model. And again, it stems in three main pillars. The first one is to identify them, in this case, identify those who are frail, not only in the hospital, but in the place where they are living, in the place where they are based. Second, to bear in mind the care pathway. And third, how to translate them once they have been discharged from the hospital, in our case. WHO, with the same conceptual framework, has also proposed this model of care that is called ICOP, and it's now being tested in several countries around the world. And the European Union also has proposed recently, through this joint action, Advantage, a model of care that try to establish and improve this integrated model of care to completely, and this term completely is very important to bear in mind, to address frailty, which the same general issues with the same general ideas supporting them. And this is also the case for the National Health Service. This is a nice document that I truly recommend to all of you, because it's a document about comprehensive care, but in all the people living in hospital. So this comprehensive care does not mean only comprehensive care along the different settings of care, but also inside each of them. And for instance, in England, support for all the people living with frailty now is among the 3 priorities for the National Health Service, along with mental health and cancer. And in this document, they split the moments of care in 4 big chapters. The chapter 1 is when the old frail people is approaching hospital, with the main attention paid to emergency department. Second, how to approach the patient during hospital stay. 3, how to prepare the discharge of the patient from the hospital. And finally, in the chapter 4, how the patient can be followed once he or she has been discharged and is living at home after hospitalization. Summarizing the issues, we have a patient in the middle. We have several systems of care, the primary care, social services, and specialized care. And we have here the service of geriatrics, which is in the hospital. I am going to show you how my geriatric department is organized. And we have several units in our service of geriatrics. We have a unit for acute care unit, for rehabilitation unit, outpatients office, geriatric day hospital, liaison services, and attendance to community care unit. All of them has their programs, and all of them are interlinked among them, interlinked with other hospital services, and also with outpatient services like primary care and social services. And for doing so, we attend the patients at the hospital, but taking into account that in the hospital, we are also only attending 5% of all those people. 95% are living abroad the hospital, but they are the weakest, or they are in the weakest moment of their lives. And again, sorry for insisting, but I think it's very important to bear this in mind, that we can think in the patient, thinking in the patient, not only at the hospital, but also when he or she is going to be discharged from the hospital. Why the hospital merits special mention? When I showed you the pathways from robustness to disability, if you remember, I showed you how stressors is going to impact in these people and to produce disability in them. Wait, probably the most stronger, the strongest aggression, the strongest stressors for a frail person is an hospitalization period. And this is why when you decide if admit to the hospital or not admit to the hospital a patient, for instance, in the emergency department, you must be very careful because you are putting the patient in a very critical, in a very risky place for them. We know that function does not recover spontaneously, and this is another problem. But since some evidence, we now know that functional impairment can be avoided during hospitalization and also can be restored in some way during hospitalization or after hospitalization, as I am going to show you in my next slide. The previous study I showed you is near 20 years ago, but this is very recently. This is a study done in Madrid, in the Hospital Clínico, with people older than 80 years old that had been admitted to the hospital due to COVID, and how their functional status changed from immediately after discharge, 1 month later, 12 months later, and 18 months later. Probably is one of the studies with the longest follow-up of these patients. As you can see, in green, in blue, sorry, is those who worsen. And as you can see here, no matter the scale you are going to assess, there is no changes in those who worsen at 1 month, 12 months, and 18 months. So those who suffer a worsening in their functional status did not recover it spontaneously. How to approach these patients? We should approach them from a standardized way with 3 main pillars. First, to screen and diagnose. Second, to provide early interventions, and then to provide them with a proper follow-up. Of course, according a plan, but you know that plans are not in the real life quite close to those that we have designed in our minds. And in fact, we have to work with so many things, with so many issues that can change the plan, that many times is difficult to provide a plan. And this is very difficult, very important, because depending upon the plan, we are going to have some practical implications about what to do or what not to do. The first issue I would like to approach in a practical way is how to assess frailty in hospital settings. You know that functional status is a very challenging issue to be assessed, because there are no strong difference between this robust and this absolutely disabled. But in fact, we have to assess in this part of the pathway. And we need to do that because people who are apparently the same are not the same. And we need to screen and diagnose those who are going to be at the highest risk in order to provide the most appropriate intervention for any of them. And for doing this, we need tools. The problem is that many tools, that the majority of the tools that has been assessed has been done in cohorts, in epidemiological studies, in community dwelling studies, not in clinical issues, in clinical settings. For approaching this challenge, we made 2 main studies. That was Frail Clinic and Frail Tools. I am going to show you the results of this study. The first one of them is Frail Clinic. That was a multi-center and multinational study carried out in 3 European countries. And we assessed the performance of the tools in 4 settings of care and in 2 phases, an observational phase and then an interventional phase. These are the tools we assessed. 1, 2, 3, 9 tools. And this is the sample size, around 717 patients distributed in these settings of care. All the patients were assessed with all the tools. So the place for bias, depending upon this, is very, very, very low. And this is one or some of the results. First, the prevalence of frailty in clinical settings is much more higher than in general population. In fact, the aggregate is 42%, and in some settings, like in emergency room, it reaches 60% of all people older than 70 years old are frail. The second observation is that depending upon the tool you are using, the prevalence is quite different. For instance, here in emergency room, according to Frail, 40% are frail. According to Groningen, is 75%. And also, it's different, the feasibility. While, for instance, Frail is can be passed to near all the patients, this is not the case for the frailty phenotype, that it's only able to be passed in 70% of the patients attended in these non-geriatric settings of care in the hospital. And this is the main cases for not being able to implement the tool. The second issue I would like to show you is how is the concordance between these tools. We have some preliminary data backed in the community. This is a very nice study published 5 years ago, in American Journal of Epidemiology, in the community. If you can see in the left part of the slide, the concordance is very low. Blue color means low concordance. And this is the case for near all the instruments among them. When we assess this in the clinical settings, what we found was something very similar, with a very low agreement, a very low concordance. These are the two higher. That's the one is between Tilburg and Groningen. Remember that both of these two tools are very related in their composition. And the second one was between FRIT and Frail. You know also that they come from the same conceptual framework, and some of the items are quite close. But anyhow, all of them were fair or moderate, not very big. And this raises some issues. The first one is that the tools use subjective classifications. Second, in fact, they are not able to check frailty. And what is in our understanding, the most plausible explanation is that although they are assessing frailty, they are not assessing the same subtype, the same clinical entity of frailty. So in this part, we have found that frailty is a highly frequent issue in this older people and in these settings. Second, based upon the feasibility and predictive ability, I have not shown this data, but they are. We have this data. Frail scale, clinical frailty scale, and frailty phenotype, taking into account the problems of feasibility for frailty phenotype, are likely to be the preferred choices between these instruments in non-geriatric settings of care. And third, the low concordance amongst the tools, the difference in prevalence reported and predictive ability suggests the existence of different subtypes of frailty. Okay. And what about in geriatric settings? This is the study Frail Tools, published in 2 papers, this one in JAMDA and another one in the Journal of Cachexia. And again, we found a high prevalence of frailty in these clinical populations. In the case of geriatric wards, 60% of people not severely disabled, that was one a criteria of exclusion, admitted to a geriatric ward are frail. 74% in nursing homes, and the lowest one in general practice in primary care. because in outpatient office attending in geriatric department, 22% of them are frail. And again, the concordance between the instruments are very low. Any of them, of this kappa index, reach the threshold of the 0.6, and that's mean that it's fair to moderate, nothing spectacular. And in this study, we made another step, that is, if there was some differences in the ability to predict adverse events. And this is what we found. What we found is that all of them are able to predict outcomes like basic activities of daily living worsening or mortality in 6 and 12 months. But if you look at this, the odds ratios were quite different, ranging from 1.79 to 3.20, near twice between these instruments. And this is also the same for mortality, from 2.02 to 4.76. And this is also when we went to the different settings of care. Here you have the aggregate in all the settings of care. And when we analyze, for instance, the impairment in basic activities of daily living, there are differences by tool and also by setting of cares in order to decide which is the most preferred tool in each setting of care. So the conclusion is that there is no single frailty instrument that always achieves good enough sensitivity and specificity to detect all adverse outcomes. So there's different for each setting of care and for each outcome. And we suggest that patients detected as frail as an inpatient, what may be accomplished with the Frailty Index 35, the shared Frailty Index, or the Frailty Trait Scale 5, should have the suspicion of frailty confirmed after discharge. Okay, what about improving the management, both in emergency rooms and during hospitalization? So we have reviewed the issue of screening and diagnosis. Now we are going to approach the issue of the early intervention. Very recently, the American Geriatric Society and the Society of Emergency Medicine have released a nice document where they analyze the issue of the emergency department in geriatric healthcare. They provide this scheme where you can see the emergency department is in the middle of all the pathways, of the routes that are walked by and other patients in contact with the health system in general and with the hospital in particular. And I'm going to show you some data about inappropriate admissions. You know that one of the problems in the emergency department with all the people is to decide who is going to be admitted and who is not going to benefit to be admitted. And there is a generic definition of what is an inappropriate admission that is 20 years old and was provided by the Royal Society of Medicine in UK. And they say that admissions whose objective, diagnostic or therapeutic could have been performed on an outpatient basis instead of on an inpatient basis, or at a level of care with a lower degree of care. The causes are different between patients coming from nursing homes or coming from their home, but they are at the same time quite similar, and the prevalence ranks from 5% to near 30%. That represents a high figures for these inappropriate admissions. So we check an intervention in patients with a very precise phenotype. There were patients, a precise phenotype with a high probability to suffer from this kind of inappropriate admissions. There were patients older than 75 with a poor baseline situation and with previous admissions in the service of geriatrics. So we have notice about them and we have a care plan for them, or without previous attendances in the emergency department. Intervention consists in that patients who meet this criteria and when the attending physician had decided to admit the patient to the hospital, before doing this, he or she made a call to the geriatric liaison teams. And geriatric liaison teams went to the emergency department and reassessed the patients. And these are the results. The results is that after being assessed by a geriatric team, 62% of those patients that initially were going to be admitted were discharged. Were discharged to several settings of care, nursing homes, to the program of liaison at home, to the GP. But the issue is that 2 in 3 of these patients were discharged from the emergency department to other settings different from the hospital. And this in some way illustrates how a proper geriatric assessment in other patients in the emergency departments is able to avoid unneeded admissions, unnecessary admissions. Okay, now I'm going to show you some results about how to manage, or some ways to manage, other people who are admitted to the hospital. We have published some years ago a study showing how physical exercise is able to improve the outcomes of patients admitted by acute illness in the hospital, and in addition, in a not very long-term stays. I remember that in this study, the mean stay, I think, was 6.5 or 7 days, and the mean number of episodes of physical exercise were 5. So this apparently very, very low intensity intervention provide very, very good results. As you can see that it produced improvements in SPPB, in Bartle index, and also in other non-physical domains, like is the cognitive one or the quality of life. And here, if you compare those in the control group against those in the intervention group, those who improve significantly are much higher in the intervention group as compared with the control group. Now we have made an intervention in people who are frail. First, they were characterized as frail, and then we provide an intervention on them. And we have assessed the results of this intervention. The control group was usual care by the usual physicians in non-geriatric settings. They are in cardiology, in emergency room, in surgery, and a geriatric team went to see those in the intervention group. And in addition to the usual care, we make recommendations to the attending physician about how to manage these patients. Not all the recommendations were followed up. In fact, 77% of the attending physicians implement the recommendations of geriatricians, but another 23 did not. And this is why we made 2 kinds of statistical analysis, one by intention to treat, and another one by per protocol. This is the patients. They are really old, mean ages 83 and 82, with high comorbidities, Charlson index 6.9 versus 6.5, with a good generally functional conditions, of course, with more females than males, that is usual, and with this population. And this is the intervention. The intervention consists in a geriatric assessment, including function, cognition, mood, nutritional, and social assessment, followed by a plan addressed by a geriatrician, covering both in hospital and post-discharge time. And their recommendation embrace the following 5 aspects: polypharmacy, delirium falls, nutrition, and physical exercise, and some of them can be extended after discharge, putting in contact with his or her family physician or a social care system. And these are the results. If you go to the right part, we have produced an improvement in Bartle index at 3 months after discharge when we analyzed by per protocol. And the results were not so good by intention to treat. And this is probably due because, of course, the recommendations are only useful if you implement them. Here, when the recommendations were implemented, we observed clear improvement in the two main outcomes of the study, at its function, assessed by Bartle index, and mortality. Okay, so now I am moving to the last part of this lecture, my very last part, that is some tips to improve the management of discharge. The patient has been assessed in the emergency department, the patient has been hospitalized, and now is the time for discharge. And to use this follow-up the patient to continue the interventions. And I'm going to show you some data from an intervention provided in a study funded also by the European Union, the positive study, following the recommendation from the WHO, when they say that there is a pressing need to develop comprehensive community-based approach and to introduce interventions to prevent declining capacity and provide also support to informal caregivers. We have done this about what I have called now for this lecture, the positive system. This is because the name of the project is positive, and it tries to provide a coordinated and continued care to the other person, providing supporting to him and to the caregiver, and also putting in communication primary care, social services with the hospital geriatric department. This is done in three main components. First, at home, there are several sensors measuring gait V, measuring power, measuring grip strength, but also through some tests assessing nutritional facts or cognition and mood. All of this data are incorporated to the cloud, and the cloud is going to provide some outputs to the patient and their care, but also to the professionals involved in the care, including some helps to the decision support system. This is how is the interface for the patient in the left part. Sorry, it's in Spanish. And in the right part, you can see the interface for the physician, for the primary care physician and the specialist at the hospital. The main part of the program is based in follow-up of the functional status. What we are measuring, what the system is able to measure, is the functional status of the patient, but is what we call the horizontal part of the system. But we also have what we have called vertical pillars that are disease related. We have pillars for diabetes, for heart failure, for chronic pulmonary problems, because the system is able to decide type of exercise, type of nutrition, type of clinical targets, depending upon the functional status. A very simple example, in people who have diabetes and are frail, the target for glycosylated hemoglobin is not 7, but 7.5. And these kind of things are provided by the system. And of course, using artificial intelligence, we are able to exploit the data, and we have provided a system of interoperability. We have checked the usefulness in clinical trials, and this the first one that has finished in 90 other persons in 3 countries, Poland, Sweden, and Spain, in the 2 groups, the control group that receive usual multi-component treatment, and the intervention group that is characterized by because this treatment is administered through the technological platform. So we are not assessing if the multi-component treatment is useful, but if the technology is able to provide in a better way this multi-component treatment. And this is the results that are very good. we have experienced an improvement of frailty in 3 months in the intervention group that took 6 months in the control group, no matter the way of assessing frailty. And we have done this in a more efficient. The use of health resources have decreased in those using the technology, and the improvement is obtained earlier in 3 months instead of 6 months. Now we are finishing a second trial that we are going to assess not only frailty, but also other outcomes like SPPB. And again, the results are clearly positive, are very good in terms of SPPB, also physical exercise and physical activity and quality of life. And we have also assessed how is the acceptance of the system. You know that there is problems of technological illiterate in other people, but we have checked. Of course, we produce this system in co-creation with other people, and when we have checked the acceptability and usability of the system is really very, very high, as you can see in this slide. Not only by the other people, but also by the professionals involved in managing these persons. So probably we can now say, paraphrasing the sentence of Theodore Roosevelt, that now we are able not only to improve the health of these persons, but also to make this in a nice and simple way. So, which are the conclusions? As in my few last slides. This is a sentence from the Economy Nobel Prize, John Maynard Keynes, and he said that when the facts change, I change my mind. What do you do, sir? I think that now we are accumulating evidence. We now have a big amount of evidence that are making the easiest to promote changes in the way of attending patients, all the frail patients at home, but also in hospitals. So the role for geriatricians in hospitals are increasingly being more and more important, because the characteristic of the patients that now are attended at hospitals are more and more usually older, frail patients. We have, or I have shown you how different parts of the whole comprehensive model of care is supported by good evidence, and how to the different parts of the attending process is improving when you apply this kind of ways of thinking. And this is an example. For instance, in my region, in Madrid, 2 months ago, there has been launched a full plan of comprehensive attention to older people with frailty, who is going to be developed in all the settings of care, including hospitals, but also, and this is my last message to all of you, this is a sentence that is in this book from William Shakespeare, that it's called in the Tempest, that is a theater opening, and he say, one of the actors say, what is past is prologue. All of the things I have told to you along this lecture is prologue, and mainly being in this geriatric network based in Frailty network, who has a big support in research, that I would like to tell you, please continue researching, continue doing research, and make true that all of the things I have shown to you is past, but is the prologue of all the things you are going to do in the next years. So this is parts of my team, and they have contributed to produce many of the results I have shown to you and have supported my presentation. So thank you for your attention, and now is your time for questions and comments. Thanks so much.
Thank you very much, Dr. Mañas. We have many questions. Let's see if we have time for a couple of them. First of all, Saori Arada asks, thank you very much for your beautiful summary. In addition to the various frailty assessment tools you mentioned, have you also incorporated any biomarkers of frailty? If you have any thoughts on biomarkers of frailty assessment management, I would love to hear it.
Thank you for this very interesting question. One of my research projects was a big project called Frailty, when we assessed 32,000 biomarkers in an effort to improve the accuracy of the frailty diagnosis. Two main results. First, only 13 of them using artificial intelligence was clearly linked to frailty. Only 13 in 32,000 biomarkers. And the issue is that when you put, for instance, in rock curves, age, gender, and frailty, you have areas under curve around 0.8. So it's very difficult that any biomarker increase you significantly the area under the curve. Anyway, we found that two of them, that was a microRNA and leptin, was able to improve this area under curve up to 0.84. So increase only in 4-5% the biomarkers, the diagnosis accuracy of the clinically used tools for detecting frailty. So in my view, now, at least now, they are not very useful. Okay.
Another question. I guess this is in regards of preventing hospitalizations. George Solis asks, are we risking withdrawal or non-provision of potentially useful treatments based on frailty status? There is an ethical issue as well when treating people based on the cost. What do you think about that?
Of course, but ethical issues can take into account what is the risk we are doing or adding to the patient, and which are the benefits. So first, we must show that making some management of these patients provides some benefits. And then we will have to balance with the risk. I am not telling that you should avoid hospitalization in older people, in older frail people. But what I am doing is, as they are at the highest risk for adverse experience when they are hospitalized, you must be very cautious when you decide who is going to be hospitalized and who is not going hospitalized. This does not mean to avoid to the patients to access to hospitalization. No, but to select them very carefully.
Very good. And now we have an interesting comment from Jose Francisco Parodi Garcia. One of the problems that we have in Latin America is how to improve the transitions between hospitals to primary care services. That's why we lose a lot after discharge when we work in the function of frail persons at the hospital. I guess that he's asking, or he's for your opinion about how to improve transitional care.
Yeah, I know. I agree with Pepe Pancho. I agree with him. But this is the case in Latin America, but not only in Latin America. In France, in Italy, in Germany, in Austria, that are very well developed and apparently or wealthy countries, they have the same problems because their health systems were designed in a moment where they do not, the percentage of people with chronic diseases impacting on functioning, that is the characteristic of all the people, not only to have many chronic diseases, but impacting the functioning. That is the particularity of geriatric patients and geriatricians were very infrequent. But this is also the case in the United States. Before starting this lecture, I have the opportunity to talk with Jorge, and some years ago I visited his marvelous hospital in Miami, the Veteran Administration Hospital. And one of the problems we were talking about is how they provide attention to the patients once they were discharged. The Veteran Administration is the second budget in the American administration, has huge amount of money. But at the same time, they have the obligation to provide care at home to any of the veterans attended. This means that sometimes they have to provide care for people living 60, 70 kilometers far from the hospital. So they have problems to do this, and in fact, they have some contracts with other organizations because they have not solved the problem of continued care. I think that now, in 90% of the countries, the main problem is to provide continued. Integrated care needs to be continuum care, because if there is not continuous care, we are not doing a good geriatric care.
Exactly. So we have to finish now, Dr. Mañas. Thank you very much for your participation. And I would like to remind a few things that the most important one is that on March 8th, we have the next seminar, which is going to be conducted by Dr. Olga Teut from Canada. I would also like to remind our participants that we will appreciate if they fill up the evaluations at the end of the webinar. And finally, the ICFSR meeting from March 22 to March 24 in Toulouse, France, where the Global Frailty Network will be present, conducting some interviews. So thank you so much, and see you in France.
Okay, thank you to all, and I hope not bothering you.